I see that AI will become the digital assistant for physicians and a really personalized version of that, where they can understand your preferences and help you throughout your clinical day with both clinical tasks and non-clinical tasks. And I expect that to come fairly soon, within the next few years.
This is the Visible Voices podcast. I'm your host, Dr. Resa E. Lewis. Picture this audience, and I'm talking particularly to the doctors and healthcare workers. You're using an AI tool to, for example, read EKGs or analyze ultrasound images. The AI tool seems impressive, but you actually don't know how it works. Who is responsible when it's wrong? Are you at medical legal risk? Questions like these aren't just hypothetical anymore. Today, I'm speaking with Dr. Sarah Gebauer, an anesthesiologist and RAND senior researcher who's a leading voice in physician, AI, and AI education. Sarah first came on my radar due to a BMJ Evidence-Based Medicine publication. This is entitled Survey of U.S. Physicians' Attitudes and Knowledge of AI. Then I started reading her newsletter. I started all the way back from July 2023, moved forward, and it is appropriately titled Machine Learning for MDs. Dr. Gebauer, Sarah, welcome to the Visible Voices podcast.
Resa, thanks so much for having me.
It's amazing to have you here, specifically for our AI in Healthcare series. I mentioned in the intro your newsletter, Machine Learning for MDs. Why did you title your newsletter Machine Learning for MDs and not like AI for MDs?
That's a great question. I actually started it before the big AI boom. Machine learning is the fundamental form of AI. AI is a small circle within the larger circle of machine learning. So there are many forms of machine learning, and generative AI, which is really where the innovation has come in the last several years. But machine learning is used throughout medicine in many different ways. And I wanted to be inclusive of all those approaches to giving us this new and informed way of thinking about how we do things like risk and how we look at scenarios and predict patient outcomes and how we can help patients, which is really my goal and my focus. How do we help patients with this new technology? How do we make sure that it's actually going to be beneficial to them and to some extent to us as clinicians as this technology moves forward?
Yeah, it's never wrong to have patient-focused care, patient-centered care. And when you started the newsletter, I was wondering, what gap were you looking to fill?
I had been on a sabbatical for 5 months with my family and just learned everything I could during that time about natural language processing. And just because, like you, I love languages. I speak Spanish fluently. I'm going to learn French soon in France. And I just thought the concept of teaching a machine how to learn a language was really fascinating. So I did a deep dive into that and then started talking to physicians in the field and saying, how do you work with this? What do you think is going to come next? And how can I be involved? And what I heard from a lot of physicians was the word lonely. So they said, I am working on this project. My chair doesn't really get it. I don't know anyone else who's really working on this. So I started a Slack group really to connect the literally 17 smart people that I knew who were working in this field. And then it has now grown to over 500 physicians over the last few years. And similarly started the Substack to help myself learn over time and to help myself have a forcing function to continue to learn about this topic that I find really interesting. And over time, I've found others who also are really fascinated by this subject and are really excited about how to use it to advance medicine.
It's almost as if you have seen the questions in my show notes, because I literally was going to say, how many followers, how many people do you have on the newsletter now? So that's perfect.
We have 1,100 now on the newsletter and 500 in the group. So the fact that there are 1,100 people who are interested in a deep dive into healthcare AI governance and evaluation is really exciting to me.
Yeah. I think people realize that they need to learn it. They want to learn it. There's gravitas. Who better to educate them? Someone with advanced training in informatics who writes about this, who speaks about this. And I think after today's podcast, we'll put in the show notes how people can follow along with the newsletter. You'll have hopefully even more following. From the newsletter, we have a transparency problem. You basically focus a few of your newsletters on EKGs and AI interpretation analysis as, I think, an excellent illustration of sort of pearls and pitfalls, where to be careful. So can you walk the audience through EKG and EKG AI software analysis and where the positives and where the challenges are?
Sure. And it's a great question because it's something that we've accepted in medicine for years. There has been EKG analysis on the EKGs that I read throughout my career, which is now over 20, 25 years. So when we think about AI, a lot of people think, oh, this is brand new. We haven't seen this before. This is the kind of technology that we've actually had for quite a while. We just have never really questioned why we're getting the answers that we're getting. We kind of say, okay, says it's normal, so it's probably normal. And we've moved on. But we've also continued to have what we would now refer to as human in the loop. So we've continued to have the cardiologist look over it to get the final read. And in a lot of ways, that's very similar to how we're approaching the new AI systems, just without that understanding all the time that this is a process that is actually kind of old and that we're adapting for a new but similar technology.
Can I just add in, as an emergency medicine physician, I was always taught, cover up the computer reading and make sure you read it yourself for the exact reason you just pointed out. The computer, which is not the computer, the AI EKG analysis software could be wrong. And as the physician, you are liable. So you actually do a deep dive, though, talking about the different companies and why the physician needs to understand like how responsible, how reliable the company and the AI software is. Can you share more on that piece of it?
Yeah, the companies aren't held to a standard necessarily in terms of what kind of data they've trained their software on, how the technology underneath works. Certainly they have to go through a process to get approval, but they're not all necessarily the same in terms of when they're likely to overcall something, when they're likely to undercall something. And each one of them does have an underlying algorithm, of course, that looks at the pattern of electrical impulses and the visual imprint of the EKG, and then determines what the actual sinus, arrhythmia, those kind of pieces are within it. So without understanding what that algorithm is, which are almost always proprietary and we don't really understand, then you can't get a sense of, for each of those different possible scenarios, how likely it is to be wrong in each one of them, and for each kind of patient. As we all know, patients with different kind of body types or different kinds of naturally occurring changes in their physiology might have different kinds of EKG patterns. And we know that most of the time they are sensitive enough to pick up some things, but not all things, which is why you were taught that in medical school. But each of those proprietary algorithms was created by a person, and we don't know exactly why that person included different pieces of it into the.
Yeah. And correct me if I'm wrong, you talk about appropriate usage, you talk about market forces. And when I brought up this, that we have a transparency problem, that importance of transparency is not yet valued. What do you think will change this?
So I think there's an important piece with transparency, because transparency should mean that we understand when and how to use the product in an appropriate way, just like we understand when and how to use drugs and what kinds of patients, and what kind of scenarios, what kind of settings. I think sometimes people get really hung up on the aspect of transparency that says, I understand exactly how every single thing works within this. And that just is probably not realistic at this point in our technology journey as physicians. And I also think that we use a lot of things in medicine that we don't know exactly how they work, but we know what patients to use them in, when it's safe, when it's not safe, and what kind of precautions we should be using when we use it. So a great example is Tylenol. Another great example is anesthetic gases. We don't really understand. We think we kind of understand how it works, but we don't really understand how it works. It is actually a little bit of a black box when someone uses an anesthetic gas still. But we do know how to use it clinically, how it is appropriate to use it in different patients, and what to look out for. And that's a really important piece of the transparency, is using it appropriately, like we want to, and making sure that we do no harm with these tools.
Yeah, I'm really glad you highlighted this, because this goes into what I mentioned in the intro about risk. You have shared that physicians will likely continue to be held responsible for these AI-assisted decisions, these AI-assisted tools. So how should physicians think about this responsibility vis-a-vis liability, medical legal risk?
It's a great question, and one that I've talked to lawyers, actuaries, and other risk management professionals about, and really no one knows right now how this is going to shake out realistically. Until there start being jury awards based on AI use, we really don't know if using an AI tool will increase or decrease your medical liability. I think there are a lot of people who think if you're not using an AI tool, you may actually be at increased risk because your decisions, you're saying that you don't think you need help for any of your decision making. There are others who think you're at much higher risk because they think that because the AI tool is often a black box, you may not be able to predict why you're getting a decision. And if you offload your clinical judgment to that tool, then you're at higher risk. As always, the boring answer, probably right for right now, is that you just have to document your clinical decision making. You can say, I considered this piece of additional information, which is all an AI tool recommendation is at this point, is it's an additional piece of information that you can take and add into your clinical judgment and then make a final decision with. And doctors have to do this all the time. They have to take a lot of ambiguous sources of information and weigh how important one is over another, and then ultimately make a decision. Those decisions are often not clear, especially for someone like you in the ER. You often don't have all the information before you're having to actually start treating someone.
It's super interesting to me that you mentioned that, we might not know until there are jury awards, because within emergency medicine, you and I shared that my expertise and sort of deep dive has been the use of ultrasound at the bedside. And for a long time, people that didn't train with ultrasound avoided ultrasound until people started writing the medical legal risks. And one of the first case series found that the times that ultrasound caused a problem with medical legal liability was when the physician did not use ultrasound. It wasn't that they used it and even made a wrong interpretation, is the fact that they failed to utilize what was now considered a tool that was standard of practice for better, safer, patient-focused care. And so it's not surprising that this is analogous as we're getting more of these AI tools.
And it's also interesting that we don't know how the patient experience using AI or knowing that AI was used will affect their thoughts and feelings about when something inevitably does go wrong in healthcare. And there are initial studies that, for example, there was one study that shows that when an AI interacts with a patient, and when a patient interacts with a physician, they actually prefer the interactions with the AI, mostly because the interaction, the text is longer and often more empathetic because it has more words to it. But then when they're told that it's an AI that they're interacting with, they then prefer the physician response. So people do have feelings about how AI should be used, and kind of a really innate human and hard to explain feeling about what that means for where the responsibility should lie. Don't think that we know as a society yet how to assign blame for when something bad happens yet.
Yeah. I really love how you have highlighted in your writing about this more along the lines of transparency, that, we should be letting patients know when we're using AI and AI assisted tools. As I shared in my intro, you came on my radar when I read your article published in BMJ Evidence-Based Medicine 2024. This was a survey and looking at what do physicians know about AI. What surprised you most about their attitudes?
I was actually so pleasantly surprised that almost everyone wanted to know more. Physicians have a pretty rocky history with technology implementation in the workplace. Our history with the EHRs, I think we can say that there have been some great things about it. I know now if a patient is getting pain medicines across the state, for example, that's wonderful. But I think on a personal level, a lot of physicians feel a lot of weight from having to do a lot of click boxes and time in the EHR and have pretty mixed feelings about it. So the fact that despite all of that, almost everyone that responded to the survey actually wanted to learn more about AI and wanted to have more knowledge about it was really encouraging. And I think really important because doctors do know when something's important and potentially transformative. And at the end of the day, if they think that's going to help their patient, they will do it, even if they're tired and even if they are not maybe up for learning something new after a 12, 14, 18-hour day. If they think it'll improve patient care, they'll do almost anything.
Yeah. Vis-a-vis that survey, the N was about 80, 82 people that responded to the survey. It was a short period of time. Was your thought with your co-author that this is a good proof of concept? Let's get it out there?
Exactly. And it was done pretty early in the ChatGPT revolution. So we really wanted to figure out, are people going to be interested in doing more of this? And clearly now I think not just physicians, but as ChatGPT has gotten easier to use and Claude and all these tools, people are adopting it at higher rates and everyone is using it more and more. At the time that we did the survey, that wasn't clear that that would necessarily be the case. It was still harder to access and really a newer piece of technology. And I think as people have gotten more comfortable with using it in their private lives, that has spilled over into medicine also. Now that they are able to identify what is it good at, what is it not good at, what should I actually use it for, then people can even see the use cases more clearly after using it in their private lives.
Yeah, you mentioned that physicians maybe historically are slow on the uptake regarding technology and innovation, but I guess I would say that maybe we as individuals have that agency, that interest. We're all liberal arts nerds, but I actually think it's healthcare and healthcare systems. In fact, I think back in 2000, there was a study or a descriptive piece that basically said that things that are known to be useful and patient centered take an average of 15 years to actually filter through and be adopted within healthcare. So sometimes I think it's sort of the viscosity of healthcare a little bit more than physicians as individuals.
I think so too. And I know that study is based on FDA clearance, which of course adds 5 to 7 years in the in the middle. And I totally agree that physicians are pretty up for new things and kind of have a bad rap for being a little crotchety about technology. But I think they're crotchety about technology that they feel like gets in the way of their patient interactions. So if something facilitates their day and their patient getting better, they will do it. I mean, I think we can witness that with the ambient scribe uptake has been very, very high. The use of prior authorization of ChatGPT for prior authorizations was almost immediate amongst physicians because it's something that they hate doing and that ChatGPT does a quite good job at. So if it actually is useful technology, doctors are pretty good at it. And I think they have over the years come to be seen as technology phobic when that's not actually the case.
Yeah, you led me right in the FDA and the regulatory landscape. Some more words because we love words and we're polyglots. SaaS and SAMD, meaning software as a service and software as a medical device. Can you tell the audience why these are important distinctions and the FDA really focuses on them?
Yeah, it's an interesting time right now, both here and abroad. The regulatory agencies are really struggling to keep up with AI technology. These are government offices who don't have large machine learning teams, and nor can they pay them. So they're really trying to figure out a way to deal with these and regulate them appropriately. Just in the last few weeks, we saw the National Health Service start to regulate ambient scribes, for example, as medical technology. And so people are wondering, and some are expecting that that kind of regulation may come into play in the United States as well, for example. Most of the technology that's implemented right now is actually SaaS. So it's software as a service, meaning that it's the same as implementing any kind of IT program that you would normally implement in a hospital and doesn't go through a process to make sure that it's clinically safe. Software as a medical device is really something that the FDA originally was planning to be used for things like pacemakers. So making sure that the software that underlies a pacemaker, for example, is safe for use and will keep people alive. As they've tried to make that umbrella cover more and more of the products that are being used, that original way to describe software as a medical device is becoming increasingly obsolete. We are using a lot of these tools in clinical settings in ways that are impacting clinical judgment, whether or not they fall under the specific guidelines of the software as a medical device area as defined by the FDA. So I think there will likely be continuing guidance. There is now guidance for AI specifically. The software as a medical device makers do have to submit specific plans for example, training and model updates in terms of how they deal with those. And they don't necessarily have to describe exactly how the model will change every single time there is a update to a model. They just have to describe the parameters under which that would occur. So there are some changes happening, and I expect that distinction will become, it's already very fuzzy, but it will become a a little more regulated as we go forward in the next 5 to 10 years.
Again, my lens is ultrasound, and so I've seen this with devices, regulatory bodies like the FDA. How is it outside the US, like Europe, Asia, in terms of getting clearance and approval?
Europe is much more regulated, and they are much more stringent in terms of what gets through for their medical devices and for AI in general. So Europe has its GDPR Act, which encompasses all of the different ways that AI could harm society in general. So it has information about protections and for consumers and for bias and for privacy and those kinds of things. In the US, actually, a lot of the regulation right now is coming from insurance agencies. So, or sorry, not insurance agencies, but insurance commissions.
I was going to say, pause. The audience were all like jaw ajar, like, what? Insurance? But go ahead.
So insurance commissions regulate that they are not allowed, places that provide insurance cannot discriminate against people. So this comes in to when, for example, health systems self-insure and are providing insurance for their members or for their employees. They have to make sure that they're not discriminating against any of those people. Lack of bias and that focus on bias and fairness is really the first piece of regulation that people really have to comply with. And so that's been really the focus of a lot of the evaluation and governance aspects that hospitals have incorporated so far. The other aspect, as you mentioned earlier, is there are some laws in California and Colorado and some other states that say that if you are interacting with a chatbot, that you have to be informed. And so those kinds of laws I expect to be increasingly common state by state also, but these are state laws, not federal laws at this point as well. So the federal landscape in the US, just by historical precedent, is much less regulatory than that in Europe.
It's a great time to highlight some of your work in the rubric space. Recently in a newsletter, you wrote that you built the rubric you wish you had. And specifically, I'm talking about Validara Health. I'm going to read a little bit about it, and then I want you to riff and tell the audience more. So Validara Health bridges the gap between healthcare AI innovation and clinical reality. Founded by physicians and technology experts, we provide comprehensive evaluation services to ensure AI healthcare tools are safe, effective, and truly valuable in clinical practice. Go.
Well, I had been working at RAND, really helping to create the model evaluation science for national security issues. And a lot of that is really evolving right now. It's in the last 6 months to a year has grown quite a bit, but we still don't know the answers to fundamental scientific questions in terms of how many times do you have to run a model, a probabilistic model, meaning it will not necessarily give you the same answer every time, to know that something is safe. How do you measure the amount of help that a model might receive or a person might receive from a model to do something dangerous? For example, how many people, what kinds of people should you be testing? What kinds of scenarios? And how many times do those need to be run to give you a definitive answer? So as I was doing this kind of work, I realized that many of those same issues existed in healthcare, that a lot of times we don't know where the risks are in healthcare. And even when we do, we don't really know how to develop the metrics, how to run the tests, how to figure out if these are clinically safe or not. And I think AI has amazing potential to transform healthcare, but I also think that if we implement it in a way that's not safe and that harms even responsible and even harms a few patients, then we're going to slow down the entire field. And some of these technologies that could really help our patients won't get to them.
Yeah.
And it won't be because they weren't good technologies. It'll be because we didn't do the kind of testing to make sure that they were being used appropriately in the right kinds of patients and the right kinds of settings, and that we didn't look at them in a way that made sense for the actual workflow and the clinicians using them. And that's, I think, a piece that often gets lost in translation from the machine learning experts who are creating these tools into the clinical practice. And Resa, you are well aware of how many ways things can go awry in a very simple workflow, even in a busy ER with a lot of people, a lot of patients, a lot of things happening. And when we look at the evaluation metrics that are usually used in a lot of machine learning evaluations, we see things like area under the curve, and we see things like a blue metric, which is a metric for semantic similarity, meaning it says what you think you want it to say. And as physicians, I think we have this really felt sense of things can be so good on paper and yet we've seen them fail over and over in practice. And not just that they just don't work, but they also even have the potential to actively harm the workflow in a way that if it takes my attention away from what's important and the patient in front of me, then it can actually negatively impact how that patient is cared for. And I don't want that to be the reason that a patient has a bad outcome. And I also don't want that to be the reason that we don't capitalize on this potential transformation.
Yet another opportunity to talk about healthcare design, human-centered design, making sure the end user is at the table during that design process, iterating, prototype, going back to question. Like, it's just such an important process so that what gets spit out as the final device, workflow, AI tool it may not be perfect, but it'll be much better than had that iterative process not happened. So I love that you shared your thought process behind creating this. And so I will say innovator, physician, researcher, AI subject matter expert. Sarah, when did you realize you had a voice, and when did you start using your voice?
This is such a great question. And it really was when I started the Slack group for physicians and started my Substack, which I did at the same time. And I wasn't an expert in the formal sense. I didn't have a PhD in AI or machine learning, but I had a clinical informatics degree. I knew how to code. I knew more about this topic than a lot of people that I talked to. And I was willing to have a learning process alongside my readers. And so I was learning as I went along, and I was learning as I wrote. And that process and understanding that was okay, and not only okay, but fun for my readers too, to go along with me, and that they had a lot of the same questions that I had, and that my natural curiosity was a great proxy for other people's, was really actually an exciting realization for me. And that has served me well since then in terms of knowing what to write and what to talk about and where to go. Also with my career, following that natural curiosity has not led me wrong yet.
Professional development for listeners that want to learn more. Let's say for the physicians, there are a bajillion online courses and resources. Are there some that you could name as places that physicians can go to better understand AI?
Places that I often refer to people to are A16Z Healthcare has a great list of ways to understand AI and a lot of resources there. A lot of them are lower lift than a full course. So busy clinicians can pick and choose some of those. And often they're, single use kind of podcasts or webinars and that kind of thing. There's also LinkedIn. Following some of the thought leaders on LinkedIn is often helpful. That will push to your feed some of the new developments and new aspects of the field that are happening. I subscribe to the TLDR AI newsletter, which I think is great. And it, again, pushes information to you. I found that is one of the most helpful things that I can do as a physician, is not have to go look for something. If it comes to me and is pushed to me automatically, I'm just much more likely to engage with it. And then following Substacks like mine, like some of my colleagues who write about AI and healthcare AI, those kind of pieces also are tailored for an audience that understands you already and can understand your unique concerns and how you might already be thinking about the world and frame the concepts in a similar way.
For audience members that want to follow you and your work, what's the best way to check you out?
Signing up for my Substack is always a great way. Following me on LinkedIn, I post different resources there. And then if you're a physician, you are welcome to join our physician-only Slack group for ML for MDs. And we'd love to have you there and join the conversation with, like I said, over 500 physicians who are really leading AI in their institutions.
Dr. Gebauer, thank you so much for joining me on the Visible Voices podcast.
Thank you so much for having me.
The Visible Voices podcast amplifies voices in the healthcare, equity, and current trend spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Find me at Resa E. Lewis MD on social media or visit thevisiblevoicespodcast.com. Find us wherever you listen to podcasts and watch our episodes on YouTube. This podcast is for education and entertainment purposes only. The views and opinions expressed by our hosts and guests are their own and do not reflect the opinions of their institutions. Information shared here should never substitute for clinical judgment or for medical advice. Together, we're making healthcare more equitable, one visible voice at a time.